off, we want to confirm, the plateau. Is it in fact a plateau? Or maybe it's just a slowing down, or maybe they actually got to maximal medical benefit, right? And so that's kind of the art of also being a clinician on that aspect of that maximal medical benefit. And like, here's a side note on that too. Sometimes, it may not be tissue related. It could be individually related. Like I've had some people that just, we get them as far as they can, but their lack of compliance, whether intentionally or unintentionally, because they're a physical laborer, like that's what they do for a living, and they can't stop. And so, they were better off getting surgery, and that's absolutely, fine for them. So we hit those plateaus, and sometimes again, it's part of the nature of what we do. Always looking for red flags. This is where we go back to what else was on the differentials that maybe we need to consider at this point, getting extra imaging and maybe identifying that there could be a different problem, right? And that's what's important about making sure that we have the I say the appropriate diagnosis, but especially the appropriate classification. And I say it like that because there's a study by Ghosts in et al. In 1998. I know it sounds old, but it was a retrospective cohort study, really interesting. And the way they classified the patients, and basically they were non-specific low back pain patients with an average temporal dimension with regards to their condition of 48 months, right? So chronic. But the age range was 17 to 72, 78. And so, yeah, they may have the same ICD-10 code, but that is not really the same condition, right? So making sure we kind of identify, what's going on. And then looking at the driver, like, is it that mechanical? Is it a capacity? Like, are they overloading it because they're not stopping what they're doing, and so on. And then we need to figure out what the failure mode is. So what are we going to use for those anchors, and how can we measure those to look at what the problem is and make sure we've got the appropriate selection, maybe the sequence of events. When I started in this industry in the early 90s, patients would come in the clinic that I was working at, and it was basically like whatever bay was open. And sometimes patients would come in and they may start on the treadmill. Other times they came in and they may start with ice or heat. Yes, we used to get paid for that back then. Or maybe they start with e-stim or whatever the case may be. And we now know that the sequence of events can actually matter. Certainly the dosage, which even like in the exercise realm, we've kind of attempted at least to get away from like your classic 1 set of 10 progression, 2 sets of 10, 3 sets of 10. That's maybe not the best way to kind of look at the volume load, and then certainly the adherence. So we need to figure out and probably, even if there's like 5 of those things wrong, then maybe you need to rethink some stuff. But there shouldn't be. There should only be a couple, and we probably need to just kind of start with one. So these are potential plateau patterns that we may see. I don't mean every week in every patient, but maybe if you've got 10, 20 different cases, you may come across one of these a week in one of those cases, and so on. Pattern one feels better, does not do better, right? And that's pretty consistent, especially in that acute stage to some degree. In other words, there's legitimate tissue disruption that resulted in an inflammatory response, and we all know that biochemically, when we reduce that, pain will subside pretty dramatically. But again, the tissue's still damaged, and so think about that in terms of, well, just because pain is gone, we don't go to Zumba class, right? Um, Pattern two does better, but still, right? The capacity, but they still have this pain generator, and that's where I find these kind of interesting, because it shows that correlation isn't always there. Now, in the physical medicine world, this is especially interesting because we often, when we do something that addresses the mechanisms associated with pain, we often see that co-commitment improvement in performance. But this again can potentially go back to, well, yeah, maybe they actually have some low-grade inflammation, and we're not addressing that to the extent that we probably should. Good days, bad days. Well, that probably comes along with some of these people that one, potential adherence isn't there, especially if you're giving them some home things. I love giving people stuff at home to do that is going to be managing their pain. And shout out to my friends at Stop Pain Clinical, because the other benefit of managing their pain is they're going to do what they're supposed to be doing, what they told them to do, especially on the physical component side of things. But when you give them homework and it has a double whammy of actually doing something like reducing their pain that sort of has that immediate response, which is why I like to do that, it empowers them. And if we don't want all of the responsibility on our shoulders, you must empower your patients to actually do something. The strategy never changes. We hear this a lot, especially in a lot of these facilities, that everyone's doing the same thing repeatedly over and over and over again, and they're not really going to get the hopefully the effect. And in fact, we're going to still have all the same problems, asymmetry, because they're doing the same movement patterns. Maybe they're only doing it unilaterally. Maybe they're doing it bilaterally, but they're using the same potential load, or we're just treating the pain. Which again, I'm not saying that we don't treat pain. We have to treat pain. It's imperative we treat pain. Statistically speaking, patients come in to see us because of a dysfunctional movement pattern, a reduction in capacity. Like, oh, I used to be able, I literally had a patient come in. He's like, I used to, they were snowbirds, put their bikes away for the winter. And he's like, I couldn't lift my bike anymore. So, that was his indication that something is up and needed to do something about that. So, the pain situation studies are also clear that if we don't address that, we're not going to make them happy. We don't develop that rapport. We're not showing them the empathy and the sympathy that they might be looking for. So, feels better does not do better. I see this a lot in chronic pain patients. One, just think about reducing the biochemical effect, even with decompression. And I've got one of my best patients in my history being a clinician, Martha. She was feeling better, immediately after, and then just. But as I explained to her, I'm like, we need to build on that. And that again tells us that, I didn't introduce anything into her that was exogenous in forms of a pharmaceutical. It was all mechanical and addressing, part of the different mediators causing a problem, which was asymmetry and abnormal recruitment patterns, as well as hypertonicity in the spine, which was causing, part of her pain generation. But it didn't fix, part of the problem. It was only part of the regiment, and we were still had more work to do. Shoulder is another one. I mean, think about the shoulder. Any damage to the rotator cuff, or I should say the labrum in particular, causes rotator cuff sequencing of events as well, and not doing their job, because even though it's a very slight, suction effect of getting that head of the humerus into the glenoid fossa, it's really important. Just the hanging and then the constant, tension on the rotator cuff muscles just is relentless. And so we often see when we unload it, when we do some stimulation to those muscles, they're doing their job, they've relaxed a little bit, and what are we going to do? So one, let's think about, not just chasing the pain and doing the same thing repeatedly, but think about the different mechanisms associated with that. And that's why, going back to a couple of anchors and thinking about that, how can we start to address that and build some of that tolerance? I do some kooky things, after I get them up off the table that some of you on here probably know and I've shared with, to kind of be that more progressive and capitalize on some of those changes. Does better, but still hurts. These chronic conditions, and if you look at the pathogenesis of like osteoarthritis in particular in the knee, I mean that's a bit of a continuous problem in that we get potentially desensitization, like doing shockwave on them. I almost always get an immediate positive response from that, but I almost always get a recurrence fairly quickly, because there are other factors like, yeah, we desensitize that area, which by the way is something that like the Sprint product does, and it's this. I don't know if you've seen this, but it's a neurostimulator that goes to the tissue. It's a minor surgical procedure, and it's interesting because about 60-70%, people respond. But I've also seen people. The problem is, yeah, you could desensitize that area, but the biomechanics is such that it's going to come back because if there's no strength in the quadriceps and the hamstrings and functionality and things like that. And so making sure that, well, it's going to hurt, but there's also an expectation piece. And so shifting that goal, increasing the tolerance while reducing reducing the reactivity and not allowing them to overdo it, right? And I call it the Zumba effect, and I apply it to all the different areas in the body. Classic areas, another one like in the neck. And the reason is you put them supine and you do some magic, you do some work. As soon as they get upright, posture alone is such a horrible, horrible thing that can cause generation. And in fact, we talked about that this morning with my students who were young people who could identify that. The other problem is that I used to tell in another program, when I was a department chair, my students, I'm like, listen, get really good at the upper trapezius muscle because it can be a bread and butter. It's one of those things that you're never going to run out of people that have an issue there. And think about it, like it's the only muscle that opposes itself. It has a connection to, the brain stem. Um, and it's the most powerful part generator of power output in the human body, which is the second pole that we see in Olympic weightlifting. So it's wicked strong, it's wicked powerful, and it's stubborn, and it's an area that people are going to store some of their stress. So in other words, poor posture and stress, yeah, it's probably going to come back. The roller coaster, ups and downs. Plantar fasciitis is again a very interesting one, and I'm going to talk a little bit about this in a second as well. But people often get very rapid relief from the problem. Why? Because it's multiple mechanisms, and one, yeah, I mean the associated calcaneal heel spur, right? That's a response to this problem that is otherwise going to be inflammatory in nature. It's a calcific tendonitis for all intents and purposes, right? And so reducing some of that inflammation, short-lived, quick, but there's no quick fix to if there's abnormal mechanics, therefore, kind of thinking about maybe an insert, at least for a little while. I love, I'm going to start walking around barefoot. Like, well, you're 40 pounds overweight, you don't exercise, and going from wearing shoes to not wearing shoes in your classic situation probably not the best thing, and in fact can be a cause when it comes to plantar fasciitis. The other thing in these lower extremities, especially in the ankle, remember that it is designed to produce very effective means of force, right? It's a class two lever. It's your wheelbarrow, and so it is designed to produce. So there's a lot of stress in this area, and people don't just stay off of it, right? So we need to go back to one, am I using the appropriate dose? But we need to kind of think about these ebbs and flows with regards to some of these improvements and understanding, okay, they're going to be doing some of their stuff at home. And of course, everyone has access to PubMed and various online resources to medical, and they diagnose themselves and all kind of find all kinds of different stuff. Pattern four, just, people are not changing something. And without the change, they're not going to, get to that point. And that's your classic, one set of 10, two sets of 10, three sets of 10. Not really dealing with the functional capacity of the tissues and the problems that are actually going on. The classic one that I always say is not reducing the stimulus. And actually, a coach asked me the other day, one of her athletes in strength and conditioning is experiencing low back pain. What does it take to reduce her low back pain? And I said, you need to start with reducing the stimulus. It's like, well, it was training. And I said, well, no, she had an adverse reaction. She did something wrong, and it was an abnormal movement pattern that caused that. So you need to fix that. Keep an eye on her, making sure that however she's doing her squats and so on and so forth, but reinforcing, those abnormal patterns and moving forward. This is where, so this below here is a picture that's looking at gait. and that, we see here, so your typical is going to be 60-40, and that really is going to range between 55 and 65 with the stance phase, and 35 to 45 in the swing phase. And so this actually looks normal, and it's pretty symmetrical between both sides. They've really got good, double support, but there are other nuances, again, that this can really tease out, some of those abnormal movement patterns. So whatever it is, we need to calm the problem down. We go back to the drawing board and we need to figure out, what's potentially causing that plateau, the increase in pain. So reducing the irritability and, always thinking, if in fact is inflammatory. And this is where it's challenging because that mismatch in load capacity, for example, can also cause, a backward step in inflammation. And think and I think back to there's a psychological model written by Hans Seeley, and it's about plateauing. And so this model is actually applied in physical training. And in fact, my professor for my master's and PhD program, Dr. Mike Stone, wrote an article. Look it up back in Strength and Conditioning Journal, and they talk about the monotony in training can actually not only induce a plateau, but can ingrain a plateau and make it even more challenging to get out of that plateau to move forward. And if you look at the model, the ultimate downside of doing that is not favorable. So then we need to get to a point where they can tolerate whatever it is that we're doing. And then we need to start getting to that loading effect. If we think about, again, our end goal and what we're trying to accomplish, we're trying to get people to move better, and therefore we need to create a loading scheme that's going to address that. And I put this down here, Big Mike's shoulder. So I had this dude, he specifically sought me out because he went to an amazing physical therapist, and he was specifically looking for someone to do Shockwave on him because that's what he heard. And so um, his shoulder it was being hung on by a thread. He was in his early 60s, previous competitive weightlifter, but still trained very similarly. And the guy was just built like a brick house, and didn't want to stop. And so, yep, we got some great relief, immediate improvements in range of motion. The problem was that, his loading on himself in the gym was way too high. And like I said, if you're going to get back to where you want to, dude, then, you need to decrease that and you need to load the tissue to the appropriate capacity. Okay. So building that tolerance is really important, and we can do that with our applications here. As I always tell people, Mike, the threshold for biological influence is really not very high, and so. And I use the analogy hot sauce, and so I can always add more hot sauce, but once I put too much in, taking it out is nearly impossible if you put it in rice or something like that, right? And so, but the threshold for biological influences is actually pretty low. Now, the benefit of that and not inducing an adverse reaction is quite powerful, right? And so this is, applying radial shock wave where, and call this the lumbar spine, I may start off with 50 millijoules, which sounds probably really low to a lot of people. Or if you're thinking bar, 1 bar, at only 500 impulses, thinking, oh boy, that's a waste of time. Not really. It will desensitize the tissue, right? Which is one of the factors associated with either the plateau or the initial treatment with someone. But think about creating a non-adverse situation while having a positive aspect and building what you need to do with your patients, which is rapport and trust. The other thing that I talk about from a patient management standpoint is people know numbers. They may not know what the heck I'm doing to them, and you can explain it to them for sure. But when I say, yep, we started at 50 at 500 impulses, and then now, wow, we're at 80 and 1,000 impulses, and they're like, woohoo, I'm doing a little bit better. And then ultimately up to 100 millijoules at 2,500 impulses, right? So think about that very similarly in terms of like the volume load progression in exercise therapy. It's very similar where the volume load is the number of sets times repetitions times the resistance that you're using. And so you can actually calculate the dosing from this perspective, right? And so this allows me to kind of address the pain. It allows me to take a step back. It allows me to develop rapport. It allows me to have a positive aspect, which some of these types of therapies, and I will say Shockwave is so good at desensitizing tissue and reducing pain near immediately for a very, very large percent of the patients. And that's the cool thing is because in some of our professions, they walk in and they have a they have the bar set pretty high. They're looking for something to happen and make sure that it's actually going to work. So this is the approach. You know, I treat other areas, but I do a lot of spine stuff, and so you know this is the same approach that I really use in any type of area. You know, choose an anchor. Um, the ODI, again, a couple things. One, I do a lot of gait analysis and movement analysis, but then bringing that down to something like how long can you sit for, how long can you stand for, things like that. Looking at maybe I'm overloading them. I classically see this in some areas like decompression, exercise therapy. You can always add more, and it can actually be pretty rapid, right? Um, we see this even in the healthy population, where our earlier studies on exercise therapy, that progression is really rapid because there's an accommodation effect, right? And yeah, we can overdo it, but the good news is, and I talk about this like the trans-theoretical model of behavior change, like very popular in smoking cessation, where I fell off the wagon. You can get back on and enter at these different areas. You don't have to start from scratch, especially we've already done some of the rapport building things. So small changes, minute changes, and figure out, you know, which one's going to give you the biggest bang for your buck. The knee OA. So this is an area that I'm really trying to do more in, and you know, one of my uh, uh, goals in life is to reduce, you know, surgeries and in particular joint replacements. And so I want to see these people earlier because there is again something referred to as limitation of matter. And that, you know, we're going to be limited in how far we're going to get someone. So the sooner that we can get someone, think about that in terms of hitting plateaus and maximal medical benefit. But so a WOMAC is obviously going to be a really good one. Reactivity and sensitization. That's actually pretty easy. Like I have stuff that works really, really well. You can give them some stuff at home, like topicals. You know, I love the stop pain again because it has the menthol. It also has the MSM. And we could talk about nutrition at a later date, but there are some really, really cool and unique things that can affect that, but then start to think about, you know, what is going to support that. And so some really simple changes is kind of, again, looking at the biomechanics and figuring out that, yeah, I get your pain is reduced, but you're not, you know, going to be running upstairs anytime soon. Like we've got some work to do prior to that. And that, you know, that's going to reduce the flare-ups. It's going to reduce the roller coaster kind of effect that we see. Plantar fasciitis is again, it's an interesting one because the literature suggests that it could be self-limiting. In my experience, people don't really want to tend to wait for that. So we got to kind of look at the factors associated with the problem, the pathogenesis itself, reducing inflammation, and there's some really good literature out there too. First step pain, they may not respond as well to a very high mechanical loading like Shockwave. That's where if they tell me they have first step pain, boop, I go straight to trying to match that up with a biochemical mediator, a stronger biochemical mediator, non-mechanical, which is going to be laser in reducing that. Okay. And then we need to look at the load mismatch. And some of that is like, how long are they going to be walking for, standing on their feet? And how can I potentially reduce that load? And sometimes it's with an insert and making sure that, by the way, if they have plantar fasciitis and they're on their feet all day, I get it. We don't want to change their mechanics a whole lot. You may consider inserts or not inserts, but that's one of the ways that there is a mismatch loading effect in that, you know, orthotics don't have to be a forever thing. They can be for a part-time thing. And I know some ways that I have a couple products that I use that are very inexpensive that are also progressive. I don't have to, worry about spending gobs of money on something that's needs to last forever, right? Um, so there are some of these conditions, which is why I chose these in particular that have a likely pattern that they're going to go to, and then I kind of laid this out sort of as the next move. So we've already talked about this, but again, we're going to provide like a take home, a one sheet sort of framework guidance that you'll be able to use. Patient communication is huge in getting them to understand. I have the probably one of the longest review of findings, but the coolest thing is at the end of my review of findings, and I have a tendency to educate so much that there's a lot of trust there. So everything else becomes much shorter as a result of that. And so the honesty thing, I'm very transparent with patients and letting them know that stuff happens. I had a police officer who always this roller coaster, and it's like, what'd you do this time? I was tracing a perp, had to tackle, and this was a female officer, tackle him down, and hurt my back again. Well, that's just part of life and something that's doing. So we always want to stay very, very positive, but being honest and know your stuff. Like, be careful getting into areas that you may not know about. Lisa D, first visit. So she was referred to me by another patient of mine. She was for low back pain. She went and got, excuse me, evaluated at another clinic, and it was a new grad. And they said at the end of the evaluation, "Yep, I'm not exactly sure what your problem is." Now, mind you, it was non-specific low back pain, but I'm going to look some stuff up. And when you come back in, I said, "Yeah," I said, I never bash another clinician because you never know what's going on. But by the way, the top ICD-10 code for chiropractors and outpatient physical therapists is low back pain. So get good at that if you're not, because you're going to see that, and even non-surgical physiatry and orthopedists as well. And so there was zero confidence after that visit, with her. So basic framework. It's not that hard, but just to kind of think about, what exactly is the process to go through and move forward. So we'll provide these for you if you're interested. You can just email me or medraylaser.com. Get on the website. Josh will take care of you. And three takeaways: define the plateau. A lot of these are predictable. Start with one, keep it simple. So this is the January kickoff of 2026. Next month, we're going to look at sequencing and combination logic that expands outcomes without expanding chaos, right? We need to make it simple. And like a practitioner, like most of the stuff I do myself, so I need to be able to roll with the punches, and sometimes it's a challenge of being the person who might answer the phone, take the scheduling, and get back to people, send emails, and so on and so forth.